Hello everyone. Welcome to another Rafael Medina Nephrology VMR today. We have two wonderful, amazing case discussants. We have with us Dr. Matthew Sparks, who is an Associate Professor of Medicine at Duke University. He also serves as the Program Director for the Nephrology Fellowship. He is the co-creator of Neph Madness and the faculty lead of Renal Fellow Network and is an advisory board member of NephSim. Welcome, Dr. Sparks. We also have with us as a discussant Dr. Alessandra Tomasi, who's a nephrology fellow at Duke University. She completed her internal medicine residency at Mayo Clinic in Rochester. Welcome, Dr. Alessandra. And we have with us an amazing case presenter today, Dr. Yahaira Jimenez. She's an internal medicine resident at Duke University and has matched into nephrology at Baylor College of Medicine. We have with us Dr. Nicola and Glenn, who will be doing the teaching points and scribing. So once we have the screen, we can go ahead with the case. And before we begin, so would you all just like to tell a few words about yourself and what you like to do outside medicine? Dr. Sparks?
Yeah, well, welcome to everybody. We're really happy to be here. Outside of medicine, I enjoy doing things with my kids. We just got back from a trip for a baseball tournament in Charleston, South Carolina. But overall, I just like doing things with my family and then also running the fellowship program, which I really like to do as well.
Ali?
Hey, good morning. Thanks again for having us today. I enjoy being outside, and it's North Carolina, so we have really good weather year round, no extremes. And right now, I think spring has sprung. I enjoy running especially and have gotten recently into cycling. So taking full advantage of our current climate here.
Amazing. Yahaira?
Yeah, Dr. Sparks is right. The pollen is pretty bad here, but it's still really nice to be outside. That's one of the things that I enjoy the most. I have a little dog, so we like hiking a lot. I like reading and I like cycling. We have a Peloton here in my apartment complex that I like to take advantage of as much as I can.
That's amazing. So we can begin whenever you're ready.
Alrighty, so we're going to get started with a case of a 49-year-old male. He has a history of non-ischemic cardiomyopathy. His EF is 15%. He also has history of CKD3A, and he is presented to the emergency room with progressive dyspnea on exertion and lower extremity edema for 2 weeks. And he is being admitted to the medicine service for heart failure exacerbation. His medications are carvedilol, 6.25 BID, spironolactone 50 milligrams daily, and empagliflozin 25 daily, losartan 25 daily, and he is on furosemide 60 milligrams twice daily. It is hospital day 2 now, and the medicine team has been diuresing the patient with about 120 Lasix IV twice daily. And for the last day, he's been having minimal urine output. And the team is noticing a downtrending sodium from 130 to 128 to 125. So nephrology is consulted for worsening hyponatremia in the setting of heart failure exacerbation and difficulty with diuresis.
All right, well, I can go ahead and get us started. Thank you for that first aliquot. A lot to unpack, and I already see some chats talking about cardiorenal showdown, so this will be exciting. First things that come to mind for me is number one, what's the baseline kidney function of this patient? You said they have underlying CKD3A. What is the baseline creatinine GFR, and what's our current creatinine and GFR? And then I think you said urine output has been minimal. I'd like to know, exactly how much urine we're making. Is this patient truly oliguric, so less than 500 cc's over 24 hours, or has the trend just been slowing and insufficient from the perspective of the cardiologist here? And then what are the vital signs? What's the blood pressure? What's the oxygen requirements? This just gives us a little bit of a sense of urgency or lack thereof. Is this patient almost in cardiogenic shock with his EF of 15, or do we have a little bit of time here? And then you also mentioned this downtrending sodium. The two are probably related, but I'd like to know, one, are there any concerns for symptoms related to the sodium of 125. At this level, I don't really expect to hear about anything dramatic, but is this patient unsteady, confused? That also lends a little bit more urgency. And then do we have prior data to suggest a baseline range? And then I think that's where I'd get started. Vital signs, what this patient is physically looking like, and then a little bit more information about the baseline urine output and sodium background.
Alrighty, so to answer this question, so his urine output has been 500 cc's in the last 24 hours with that 120 BID dosing. So the team gave him a 5 milligram dose of metolazone, and that also didn't really help the urine output. The patient has been tachycardic in the 1-teens. Systolic blood pressure has been 90s to 80s. He's afebrile. He's satting 98% on 2 liters, and he's been on that stable oxygen requirement throughout his hospital stay. On his physical exam, he has crackles to the mid-lung fields bilaterally. He has 2+ pitting edema all the way to his hips. He has JVD up to 14 centimeters. His cardiac exam is significant for tachycardia, but otherwise he has a normal abdominal and neuro exam. So he's not symptomatic with that sodium. Extremities are warm. His weight on admission was 220 pounds. His dry weight reportedly is 180. And like we mentioned, the initial labs had a sodium of 130. Now we're having a sodium of 125. Looking back, it appears his baseline is about 132 or so. Other labs, we have a potassium of 4.1, bicarb of 18, BUN of 38, creatinine of 2.1. His last creatinine was checked 2 weeks ago, and it's 1.1, and that seems to be about his baseline. Hemoglobin of 12, white count of 8, platelets are 200, BNP is 2000, lactate 1.5, AST and ALT are just mildly elevated. The numbers are 90 and 65 respectively. And we got a chest x-ray that showed pulmonary congestion, some small bilateral pleural effusions, and that's about it.
Awesome. So off the bat, and I'm seeing again a lot of really good chats here. The main issue is we have a patient who's volume overloaded in the setting of decompensated heart failure, right? And has likely developed what looks like cardiorenal syndrome. So in this particular case, kidney dysfunction, acute kidney injury due to heart failure. I like to think of cardiorenal syndrome kind of pathophysiologically. So the main insult tends to be elevated central venous pressure. And then perhaps here, there's also some impaired forward flow with that ejection fraction of 15%. Reassured by the fact that you're mentioning the lactate and how the patient's looking, he's not cool to touch, things like that, that he's not in cardiogenic shock. So that does give us a little bit of time here. Again, I do think this is an AKI due to cardiorenal syndrome in the setting of decompensated heart failure, but for completion, we should always make sure that we're not immediately anchoring. So would definitely like a urinalysis, rule out ATN, AIN, any other causes of an acute kidney injury. This is a middle-aged man, make sure that he's not retaining urine, that there's no evidence of obstruction as well. And then the hyponatremia, that's probably a byproduct of everything else that's going on, right? So this patient is hypervolemic, they're volume overloaded. And in this state, the kidneys just aren't able to effectively or sufficiently or efficiently secrete free water, right? And so in volume overloaded states, essentially your effective arterial blood volume, the blood flow, the perfusion pressure to the kidneys, it's decreased because your central venous pressure is so high. And this leads to ADH secretion because the body thinks it just needs to keep holding on to water. And that's what leads ultimately to the hyponatremia. And so this medicine team is doing a great job. They're busting out all these really high dose diuretics and trying to get this patient to pee because exactly what we have to do is decongest the patient, and we need to decongest the patient fairly quickly. Again, for completion with the hyponatremia, serum osms, urine sodium, always really helpful to get. If he's being actively diuresed, the urine sodium isn't necessarily going to tell us much from a physiology perspective, but it will tell us a little bit about, are we effectively diuresing the patient? And then the last thought before I wanted to maybe hand the reins over to Dr. Sparks for a few seconds or minutes is The team gave metolazone. That's great. We can talk about sequential nephron blockade, a little bit later in this case with diuresis. I will say use metolazone and thiazide-like diuretics with caution in patients who are already hyponatremic. This can worsen the hyponatremia. I think in this particular clinical scenario, the hyponatremia is likely due to the hypervolemia. And so you're kind of managing this risk of maybe we'll have better diuresis with the thiazide-like diuretic, even if it comes at the cost of initially a lowering in the sodium. So just something to keep in mind. I'm not saying it's a contraindication. It's just something that we need to think about weighing the risks and benefits. But I know that we've recently actually had conversations about this, Dr. Sparks, in other settings, but I was mentioning the urine studies for working up the hyponatremia. What are your thoughts on using urine sodiums to actually facilitate diuresis?
Yeah, that's a great question, and I'm a big fan of this. There is some literature that I think started out of Yale from Testani and his group, where you can use urine sodium not as a diagnostic tool, but as a tool to see how effective your diuretic dose is. And I think this has actually been a really good way to try to see how well your diuresis is doing. I mean, one of the tried and true ways we look at how diuretics work are weighing the patient in 24 hours and also looking at their urine output, both of which are very inaccurate. You're unsure exactly like how they weighed the patient. Sometimes they're not done. The urine output's hard to track. And so an alternative way to do that is by looking at urine sodium. Urine sodium is an objective measure. You don't have to, see how the patient's being weighed, either bed or body weight. And so what I like to do in that is to check your urine sodium 1 to 2 hours after each dose. And then if you have urine sodium greater than 70, then I would say that they have an adequate dose of diuretics. If they do not, you escalate the dose until you achieve that. And what that has shown is patients lose weight quicker, they get out of the hospital faster, and they've actually developed algorithms that nurses can dose the diuretics independently of the physician. So the physician writes the order for the nurse to do this protocol, and when they measure the urine sodium, they can change the dose. And I think that's been a really interesting thing. I do this all the time. I will say a few things. If someone is diuretic naive and do not have CKD, almost any dose of a loop diuretic will be adequate. If they have had CKD or been on diuretics, this is a very good strategy to use. So what I'm saying is if they don't have CKD and they've never received a diuretic, this might not actually help you that much because you're going to find that their urine sodium will always be greater than 70 an hour or two after given the diuretic. So in a patient that does have CKD, have been on diuretics, this can be very helpful so that you're not behind the 8 ball after like a day or two, which just seems like what has happened in this case here. And the other thing I'll say is that, I don't know, for some reason in the United States, 120 milligrams of furosemide has seemed to be the limit. I don't know who created that rule, and maybe this is another opportunity for us to escalate the dose even higher. So that's what I would say about it. I think it's a valuable tool. I use it routinely. I don't think it's caught on like I thought it would. And one of the challenges I had assumed is that nurses would have a hard time measuring it. But I think because it's actually kind of exciting for you to give a drug and have an immediate effect, basically you give the IV diuretic and you have the urine that's made, it really hasn't been a problem for them to get this and send it down to the lab.
I love that. Excellent, Pearls. Thank you. And I want to hone into on the dosing. In patients with reduced GFR, so let's back up. So with loop diuretics, if you think about that classic curve of sodium excretion and urine output, and you get the sigmoid curve, right? And so there's a threshold dose, which is the lowest effective dose of diuretic that's going to lead to adequate urine output where you start to rise on that linear trend. And then there's going to be a ceiling dose. There's a dose beyond which adding a higher dose or providing a higher dose won't necessarily increase urine output. And in heart failure and in kidney failure, kidney dysfunction, that curve shifts to the right and it shifts down. So in the presence of heart failure, there's less diuretic being delivered to the kidneys. That's due to decreased ejection fraction. That's due to increased central venous pressure. There's just less flowing to the kidneys. And in kidney failure, so in order for loop diuretics to work, they need to be actively secreted in the glomerulus. And so if there's less GFR, there's less loop diuretic effectively reaching the ascending loop where it can act. And so you need higher doses and you need more frequent doses. So I find this, we do this a lot in nephrology when we get consulted for assistance in diuretic management. It's give a dose, see if it's effective, and then redose in the afternoon, sometimes twice if we need to, because eventually you're going to start reaching a plateau. And if someone has a liter of urine output, that's great. But in the hospital, they're still eating, they're drinking, they're receiving medications. You want to make sure that you're net negative. And so keeping in mind the physiology here, in reduced heart function and reduced kidney function, you are going to need higher and more frequent doses of loop diuretics.
I have one question. So is there any preference of a diuretic or any preference in the dosing strategy, like infusion versus boluses, and Lasix versus any other agent? So do you have any particular preference that is there?
Yeah, I'll start with my particular preference as 8 months into my fellowship. I usually, so the first thing I do is I see if the patient is already on a diuretic at home, and then what I'll do is I'll increase that dose. So the general rule of thumb is if someone's on an oral Lasix dose, I will give double that in IV to effectively quadruple the dose. So that's to get started. I like bolus dosing. There've been studies done in the past that just don't show superiority of infusion versus bolus dosing. And I think with bolus dosing, you get the added benefit of being able to track either through urine output or, as we just learned, through urine sodium, whether or not this is effective and if you need to start augmenting. Again, there just has not been any literature to support that continuous infusion is superior. We see it all the time. If it's working for the patient, I won't necessarily stop it, but it's not my go-to to start. In the hospital, if someone's primarily hospitalized for decongestion, for acute heart failure exacerbation, I start IV because then I know what the bioavailability and absorption is going to be. And as we get closer to euvolemic state, I'll transition to oral. There is a theoretical increased absorption in Bumex and torsemide compared to furosemide. The bioavailability is closer to the IV form as well. And so in patients who especially have right-sided heart failure, concerns for decreased gut absorption, I will lean more towards torsemide than Lasix when I transition to oral. But off the bat in the hospital in a patient like this, I would definitely start with an IV bolus dosing and move forward from there. Dr. Sparks, what are your thoughts?
I'm not going to say a whole lot more than that, but I like to guide my care by evidence. And Mike Felker, 2011, here at Duke, published the dose trial in New England Journal of Medicine that really showed that, as you mentioned, that continuous dosing really wasn't any better than bolus strategy. And I think for me as a nephrologist, I also try to think about physiology. And one of the things that happens when you block NKCC2 with a loop diuretic is that you start to get downregulation of those receptors. Thus, if you're continuously blocking them, they never have a chance to repopulate. So in bolus, though, after about 5 to 6 hours, you start to lose that, and you start to have repopulation of NKCC2. So it makes to me more physiologic sense that bolus approach would be preferred over IV. And I don't understand exactly why there's a huge push to go to continuous dosing. I don't know if it's more of a way that you can just put it on and just forget about it. But I think that to me, I like to use bolus because of the physiology, and there is ample evidence to suggest that going to continuous infusion is not superior.
Oh, I'm having trouble hearing you. Am I the only one?
Yes, I can't hear. You heard me? Did you hear me?
We could hear you. Yeah.
Okay.
Thank you.
You go ahead to the next liquid.
Absolutely. So we got the urine. It was pretty bland and it was spun. It didn't have any cast or really no findings. The serum osmolarity is 280, urine osmolarity 300, urine sodium 40. The bladder scan showed a post-void residual of 80. The patient started on dobutamine for low cardiac output, and they continued Lasix. The dose at this time is 160 BID, and they continued augmentation. And there's some slight improvement in urine output. So now the patient is net negative 3.5 liters in the last 48 hours. And he's lost about 5 pounds, and he has an improvement in oxygen requirement to about 1 liter. His creatinine has also improved to 1.3, but the sodium has remained low at 125.
Okay, excellent, thanks. So first, I think the first piece of information you gave us, the urinalysis, great, there was nothing there. Confirms this is probably more of a cardiorenal physiology kind of state. And then second, with the sodium, the serum osms 280, that's low, that confirms a true or hypotonic hyponatremia. And then with the urine osm with 300, again, that tells us that ADH is on. And so again, in alignment with cardiorenal physiology. Urine sodium of 40, you know, if this patient had come in fresh and not yet on diuretics, I'd expect the urine sodium to be less than 10. But again, he's receiving loop diuretics. And so difficult to interpret in this setting in terms of diagnostically, but again, helpful to know that the diuretics are in the system. So I think here a couple of things that I would touch on. So we already talked about the physiology, but I really want to hone in on this. Cardiorenal syndrome is really, really common, right? I mean, up to 50% of patients, probably more, who have heart issues also have kidney issues, and specifically in the acute setting right now. And the reason being twofold. One, that elevation in central venous pressure. Remember, kidney perfusion pressure relies on an inverse relationship between mean arterial pressure and central venous pressure. And so with an elevated central venous pressure, you have decreased kidney perfusion, and then you have activation of compensatory mechanisms, the sympathetic nervous system, renin-angiotensin system, et cetera. And early on, the kidney is really, really good at compensating. It increases its filtration fraction, it's able to keep up. But over time, as the CVP remains elevated and just keeps adding insult to injury, I mean, the kidneys are great. They do so much, but they just cannot keep up anymore, and they cannot effectively decongest. And that's when you end up in an acute decompensated cardiorenal syndrome. And that's where you run into trouble, because then it just becomes this terrible feedback loop of increased holding on to sodium, increased holding on to water, increased central venous pressure, and just worsening renal perfusion. And then the second is the decreased ejection fraction. There's just less forward flow. There's less blood reaching the kidneys. And so, you know, the addition of a pressor such as dobutamine is always up to cardiology. I won't pretend to try to make that decision as well. Here, it looked like that did help augment the diuresis a bit, which is excellent. And I imagine that was due to the EF of 15 and the hypotension. But really what it comes down to is diurese. And you mentioned augmentation. I'm curious if they used anything in addition to metolazone. That tends to be the most commonly used augmentation. But the way this works is in order to diurese, you need to block sodium reabsorption. You need to have distal sodium delivery along the nephron. Water follows sodium. And so the more you can block along the nephron, the more effective your natriuresis and therefore your diuresis will be. There's trials that show acetazolamide in the proximal convoluted tubule can be a very effective augmentation for diuretics. The thiazides, of course, we see chlorothiazide or Diaril and metolazone. I often get asked, do we need to time the thiazide administration 15 minutes before? No, I mean, this is going to linger in the system for a really long time. If it's in there, it's going to work. So don't worry about fine-tuning the timing, just give them both. And then there's more data coming out. SGLT2s might actually be really effective diuretic augmenters as well. Hypertonic saline can be an effective diuretic augmenter as well. And this is like my soapbox now. Don't stop diuresing until the patient is clinically euvolemic, okay? This metabolic alkalosis, contraction alkalosis, also a myth if we're going to start busting out myths here. It's just because the bicarb's going up does not mean that the patient is decongested. If you look at them, they have their JVP up to the ear, you focus them, their IVC is large. Keep diuresing. If the creatinine increases, keep diuresing. You know, there's studies that show that increases in creatinine and cystatin C during active diuresis in patients with decompensated heart failure they actually portend better outcomes as long as you're achieving clinical decongestion. And so don't be scared by these lab values. The metabolic alkalosis, fun fact, that's actually very physiologic. So in the collecting duct, in order to get rid of bicarb, you need to exchange chloride. And what diuretics do is they deplete your body of chloride. And so over time, you're giving loop diuretics, you're giving thiazides, you're losing chloride. You have less chloride that you exchange for bicarbonate. And so that's why you develop a metabolic alkalosis. It's not necessarily because you've suddenly over-diuresed the patient and they're hypovolemic. It's a chloride depletion metabolic alkalosis. And guess what? You can fix it by giving chloride. Replete that potassium with potassium chloride. You've given back the chloride. If you're in an ICU, you can try to augment with hypertonic saline. That has chloride in it as well. And so just, look at the patient as a whole. Don't be scared by trends in labs like alkalosis or rising creatinines. If the patient is volume overloaded, keep diuresing, because I've always said in residency, and my residents would laugh at me, the right ventricle is a people's ventricle. It really impacts how the kidneys function. And what you need to do here is decongest. I'll stop ranting.
No, that's great. A couple of things come to mind, and there's a quote popularized by Spider-Man, which is, "With great power comes great responsibility." And anytime you escalate to other diuretics, and sequential nephron blockade is what it's often referred to, you're going to have even more electrolyte disturbances, including metabolic acidosis, also development of what we just talked about, which is chloride depletion, not a contraction alkalosis. And so you really have to be involved in understanding these electrolyte abnormalities and correcting them as they go. We do have evidence that the addition of and being a little bit more aggressive up front can lead to quicker hospitalizations or quicker discharges, better decongestion. But you also see a lot of other issues that occur because of that, like the ADVOR trial for acetazolamide, for instance. So I think those are some things to recognize and to know about this. I think there's also a question I wanted to address about urea. Urea needs to be used very cautiously in cirrhosis. We have seen cases of patients having encephalopathy from urea administration. So that is something you need to watch out for. I think also, since we understand and know the physiology of hyponatremia that occurs during heart failure, it's very unlikely that this is driven from inadequate solute content. And so I think the first thing is tackling the pathophysiology, and we've discussed that here. We do have one very new, I guess newish tool, which is a vasopressin antagonist, tolvaptan. And it has been looked at in acute heart failure, not necessarily in hyponatremia associated with heart failure, but in heart failure, because it is because of the physiology that Ali did a great job of describing. ADH increases, or a better name for it is water retention hormone, which is what happens in this. Now, I want to go back to the Spider-Man quote again. "With great power comes great responsibility," because you have to be very cautious if you decide to use tolvaptan in a patient like this. They will dump a lot of water, and so you need to use a very low dose of tolvaptan in these scenarios and see how they respond to it, because their physiology is completely altered in this situation with ADH being extremely high. And also, you need to ensure that they're not being restricted of fluid intake during the time in which you're giving them a vasopressin antagonists. Now, to be clear, the trials like the Everest trial, which I was very much looking forward to when I was a fellow, did not show any improvements in acute heart failure in that setting. But you can improve some of the numbers. You can increase diuresis. You can increase weight loss. But you really need to start at a low dose in those settings. So I think the first thing I would do is try to tackle the pathophysiology with diuresis before going to other strategies, which could create even more problems.
And I saw popping up in the chat real quickly too, we'd be remiss if we didn't talk about dialysis and ultrafiltration. That's also been studied, head-to-head patients with decompensated heart failure. Some receive clinical decongestion with diuretics and the others undergo ultrafiltration. And outcomes, the decongestion timing was equivalent between the two groups, and the people who were started on dialysis or ultrafiltration had more adverse events. And so absent an additional clinical indication for initiation of kidney replacement therapy, we do not just jump to ultrafiltration. Patients do worse. Of course, in the setting of cardiogenic shock, decompensated heart failure, the patient becomes anuric, we run out of options. Absolutely. But there's no evidence to support jumping straight to using a machine to remove all the excess fluid. Patients do better when they're decongested medically.
Give the nephron a chance. I mean, I think that's where, for a nephrologist, I think when you start fellowship, you start to recognize that when they call you, you sort of feel like the primary team's like looking at this, like watching the kidney function go down. They're trying to diurese and they're a little bit nervous. For a nephrologist, you're like, well, what do you have to lose? I mean, let's keep going. Let's push the doses higher because the alternative is dialysis. And although it is a great way to remove volume, it's a really challenge for a patient's, quality of life if they don't come off of dialysis. So to me, like one of the things that I like being a nephrologist is it gives me a little bit more freedom to be a little bit more aggressive than maybe you would if you were the general medicine team.
I remember early this year, I had a patient who had, a pretty significant cardiorenal syndrome, acute kidney injury. And every day we were augmenting. And this patient's urine output remained excellent, 4 to 5 liters daily. I mean, they really need a lot of fluid off. And the creatinine just kept going up. And every day the team would reach out and be like, the creatinine's going up. Should we stop? No, this is working. This is just reflective of fluid shifts. And eventually, I think it was maybe after 14 or 15 days of this, and the creatinine peaked at 8, and then it started to come down, and the urine output never budged. I mean, it was really, I know the N is 1, but there have been multiple studies and subgroup analyses that show changes in creatinine should not influence how you're diuresing. But exactly, give the kidneys a chance. Don't be scared of just changes in numbers. Look at the clinic, at the clinical situation and the patient as a whole.
Those are great thoughts. So I have one question. So how long would you consider diuresis? So would it be just to look for edema and reduction of, let's say, effusions, or how long do we continue this? And when do we say, let's switch to the oral?
Yeah, great question. I think I go in terms of urgency. So first is respiratory status. If someone comes in on oxygen and they're not on oxygen at home, I will continue. Aggressive is a strong word, but I'll continue fairly aggressive diuresis until we're back on room air. There's little or no pulmonary edema, et cetera. If the main indication for diuresis is peripheral edema, I go based on exam and comfort and response, right? I mean, with respiratory status, what you're trying to avoid is escalation of care, BiPAP, intubation. And so to me, that lends more urgency. Those are people that I want to be diuresing really aggressively and really quickly, get the fluid off and save them an ICU trip. For those who come in with peripheral edema, I'll start until we know it's working. And if we have a dry weight, that is very helpful. As we're approaching the dry weight, that's when I'll transition people to oral. Make sure that the new diuretic regimen that we're starting is sufficient. A lot of times we see, just the other day, I had a consult for a patient who was on torsemide 10 milligrams at home, and that was working for him until his CKD continued to progress and his GFR became too low and got behind. And so we diuresed him with IV diuretics for 2 days and then switched him to torsemide, but at a higher dose of 40. And he responded well to that. And we were able to send him home with some weight-based instructions for additional doses. And so it depends on what the presenting symptom and sign was, respiratory status being a lot more urgent than peripheral edema. And then peripheral edema, sometimes we run into cases where people can't participate in physical therapy because they have so much extra just water weight on them. Those are people that I'll keep on the IV diuretics until we have a reason to start transitioning to oral. For example, they're working towards going home. But exactly, it's what was the reason for needing the decongestion? How urgent is it? And then when are we close to being able to leave the hospital? That's when I'll trial the oral.
Can we have the next aliquot?
Absolutely. So now it's hospital day 5, and the patient was weaned off dobutamine with continued improvement in oxygen status. He's now on room air, and his weight is 190 pounds. So he is diuresed with 120 BID, no augmentation, and he's having about 2 liters of urine output daily. His creatinine is improved to 1.1, which is his baseline, and his sodium is 134. And at this point, the recommendation by the nephrology team that saw him in the hospital was to discharge on torsemide twice daily once the patient reached a dry weight of 180. So very similar to the conversation we're just having. So that's helpful. And they recommended that we continue at-home diuresis with weight-based contingencies for the patient. And well, the patient is now followed by advanced heart failure outpatient. So his plans long-term are to increase GDMT and eventual LVAD as a bridge to transplant.
Awesome. So we have a happy ending here. Sorry, Dr. Sparks, go ahead.
Oh, I was going to talk about SGLT2 inhibitors, but you can
Love
finish
it.
up.
No, let's do SGLT2s.
Yeah, well, I think that is something that since Yahida mentioned goal-directed medical therapy, I think it's important for us as nephrologists and really all physicians to understand how these work. If you Google, if you're sort of wanting to find this paper very easily, it's a circulation paper, again, from Jeffrey Testani out of Yale, plus a collection of others, including a few nephrologists. If you Google NephJC sweet and salty pee, you can get to this paper. I'll put the link to it right here. What I really like about this paper, though, is it really shows the physiology very well. By themselves, SGLT2 inhibitors really don't result in much natriuresis or volume loss. Now, when you couple them with a loop diuretic, and this is a study in which they admitted patients to several days in a facility, not a hospital, but they were research subjects that were humans, that they were giving diuretics, they were giving SGLT2 inhibitors, and they could see, how the parameters were being changed with and without, SGLT2 inhibitors are on board, how the diuretics would affect it. And what you found is that with the presence of a SGLT2 inhibitor, you had about a 25% increase in natriuresis, fractional excretion of sodium, and weight loss. And I think to me, what I look at that and say, it is an augmenter of diuresis, but by themselves, they don't do a lot. And so clinically, when I see a patient in the outpatient setting and they are euvolemic, at least that's what they look clinically, and you're starting an SGLT2 inhibitor and they're already on a diuretic, you might consider reducing the dose, both the thiazide or loop diuretic. If they're volume overloaded, it might be the only thing that's needed. Keeping their loop diuretic going at the same dose, adding the SGLT2 inhibitor will get you about a 25% increase in efficacy. And so in the hospital, that can also work to your favor. And so instead of increasing the dose to like 200 milligrams twice a day, you maybe can keep it at 120 and start them on a SGLT2 inhibitor. The other thing that SGLT2 inhibitors have done is shown that they can improve the sodium, and there has been a randomized controlled trial in SIADH, which is not a whole lot of the physiology is very similar in heart failure. And so you might see some improvements in the sodium. Now, it wasn't much. It was about 2 to 3 increase millimole per liter of the sodium, but that's another thing. So that's what I wanted to talk about with SGLT2 inhibitors. Very handy to use them. I think that they're being used more and more in the hospital. I am a big fan of that as well. But remember, when you're changing multiple things at the same time, you can really create a lot of diuresis. And so you got to be very cautious.
Great thoughts. So what is the maximum dose that you would consider would be an ideal? So when would you say I would add another diuretic, or how comfortable are we when we are saying, uh, how do I decide how many extra additional blockade do I do?
I think,
How long do I wait before I decide that?
yeah, great question. I think it ultimately depends on where the patient is currently admitted and clinically how they're doing. Again, as Dr. Sparks said before, like what do we have to lose, right? What we're trying to do here is avoid dialysis. And so I'll start with my monotherapy loop diuretic. I'll probably give it up to, like 160, 180 before I start to think, okay, if 160 of Lasix on its own isn't doing it, that's when I'll add my thiazide or thiazide-like diuretic. And, within hours, if that's effective or not, if the patient's being decongested. I have seen in residency in the cardiac ICU, patients receiving acetazolamide, hypertonic saline, spironolactone, thiazide, and loop at the same time. And if it's working, it's working. Again, as Dr. Sparks said, I wouldn't start everything all at once, but just sequentially augment. Okay, it's getting better. Let's augment at another part of the nephron, et cetera. But if the goal is decongestion, keep trying. Give it a few hours. You'll know if the patient responds or not.
I just want to address another comment. We have one of the experts in POCUS on the chat, Dr. Ria Dansel, who also happens to know a nephrologist quite well. She's married to one, and she's talking about Vexus. And I think I mentioned in a chat earlier, we didn't go into a lot of depth about it. Is like, when do you know when someone's euvolemic? Vexus is a great tool that allows you to kind of understand the floor a little bit better, because we know our clinical, listening to crackles and edema is not necessarily that good. So Vexus is a great way to do that. And it's a little bit more powerful in that I guess you might be able to get a little bit more objectivity to that by looking at the liver, look at the kidney, and try to understand, like, what do the flows look like in those organs, the venous flows in those organs. And so that is definitely, I think, gaining more popularity. I think, unfortunately, and we're still at a point where not everyone is comfortable using ultrasound, and Vexus is definitely a skill that's on a higher order of complexity to do. And so it hasn't really gained a whole lot of traction, but definitely I think that is a really wonderful way to try to understand how much volume an individual has, and might allow you to push further, because there is plenty of data to suggest that even patients that we deem are clinically euvolemic upon discharge are not. And those have a very high risk of readmission. And so if we can diminish that, I think we can make a huge improvement in our outcomes. And Vexus is a good way to do that.
When would you consider adding albumin to this entire? Would you consider albumin, and when would you consider to augment diuresis?
I don't use albumin in the absence of cirrhosis, essentially, where, hepatorenal syndrome, either diagnosis, treatment, or prevention. And so, I know that there's been theoretical and perhaps maybe animal models to suggest that providing albumin with diuretics helps with protein binding and delivery, but I'm not sure that has been validated in people, and I don't really turn to albumin myself.
I think the other issue with albumin is that we know from the liver space that, albumin is going to contribute to more hypervolemia. And I worry about that in that case. Now, we didn't really prepare to talk about albumin, but we did prepare a little bit to talk about hypertonic saline. And I think this is a really fascinating area. It seems very counterintuitive, very similar to what you had mentioned with giving someone albumin. And in someone with decompensated heart failure, giving someone hypertonic saline as a way to also improve diuresis is something that has been studied. And so I think that is a potential solution. Now, I think there's two ways in which that could work. One, it can help in the scenario that Ali had mentioned earlier about the chloride depletion that sometimes occurs and when you're diuresing someone with high doses of loop diuretics. Remember, that's not a contraction alkalosis. That's actually a reduction in chloride that was really needed. And so you give a lot of chloride with hypertonic saline, so that kind of fixes that issue. And then two, it creates a scenario where you can start to pull in fluid from the interstitial space into the nephron to remove fluid. And so I think that's another way in which that it can work. And anecdotally, you can see really good responses. Now, again, back to the Spider-Man quote. You have to be very cautious with this. So usually it's done in the intensive care unit. You still have to give the diuretics when you do this. And you shouldn't have someone with profound hyponatremia when you do it, because you can really correct the hyponatremia pretty quickly. And so that's something I've been very interested in doing. It does take a lot of investment in multidisciplinary team to write these protocols and to follow the patients and to find the right patient that it might work. So I think hypertonic saline I would probably use in the right appropriate context, but I don't think for a heart failure, albumin would be in something that I would use.
Amazing thoughts. So, one question is, could you just add a word on ultrafiltrate, and when do you really decide to go for an ultrafiltrate? So is it like we wait, if the drugs don't work, we go for ultrafiltrate? Or if the patient is having, like in this patient, we have a CKD with an heart failure. So does it reduce the threshold for ultrafiltrate by any chance or any of that?
I look at urate output, and if we've really tried our darndest with our diuretics and our augmentation, and we've done everything, and the patient becomes oliguric, anuric, certainly, everything's getting worse, and it just becomes we need to get this fluid off. That's when I'll move to dialysis or ultrafiltration. But it's really my last resort. Certainly in patients who come in with already baseline CKD4 or CKD5, the risk is much higher, and with those patients, I'll have the conversation about dialysis initiation when I see them in the emergency room head on. And I'll say, we're going to try all of these things. This is what the next 24 to 48 hours are going to look like. But there's a very real chance that with your GFR already being so low, we might not be successful here. And this may be the thing that tips us into needing dialysis. And sometimes it's temporary, oftentimes it's not. So with those patients, that'll definitely change the conversation I have, but the threshold is still the same. We're going to try medically and go from there. In patients who are in cardiogenic shock, they just got their balloon pump or their Impella placed, their oliguric coming out of the cath lab, those patients in the ICU who are really, really sick and looking at mechanical assistance with their cardiac devices, will be a little bit quicker to initiate CRRT as well for volume optimization. But every case is its own, right, and comes with its own pre-existing conditions, current acute issues, and it ultimately becomes how fast do we need to help this patient.
That's it was such a wonderful discussion. So many pearls, breaking so many myths. So do you guys have, thank you so much for being here. So any last takeaways or reflections from this case?
I can
Maybe Haida, let's hear your view on it after, from being a resident, being on this, podcast beginning, and what are your thoughts about this subject?
I think I'll keep these 3 myths with me whenever I go back to the wards. I think the first one is timing. Like I mentioned in the chat, I've been in situations where we're like, okay, we gave metolazone yesterday, we can't give it today. So timing is a myth number 1. And then the second one, this idea of chloride depletion alkalosis and not contraction alkalosis was really helpful. And then the third one, we mentioned the dose trial being showing us that there's really no improvement in mortality or symptoms with giving a diuretic drip rather than just BID dosing. I feel like my experience has been we jump as soon as we get to the 120 or 160 dosing, we jump to Lasix drip. So that's a really good learning point for me. And then I think I'll be asking nephrology a lot less as to when do we start ultrafiltration if we haven't done all the things to augment diuresis and sequential nephron blockade.
And in a few short months, you will be nephrology.
Yeah, 2 more months. It's
Yeah.
closer.
I think, it's for all the learners on this chat, and especially the learners who are still deciding what they want to do. This is one of the beautiful aspects of working in nephrology is you truly get to see everything. Like you are an internist and you are working alongside other subspecialists, and diuresis in heart failure, that's a cardiology thing. But as soon as the kidneys are involved, which is more than 50% of the time, you get the opportunity and the privilege to participate in that care and work alongside people. And sometimes it's providing reassurance. Like in this medicine team, they were doing everything right. We were really providing reassurance, it seems, the nephrologists consulting in this case, that yes, continue diuresis, and yes, you can augment, and yes, you can increase, and this is why. And we'll be here to let you know when that is not enough or to provide solutions. And so it's a really, really exciting field. And it's never a dull moment. And even if we get a lot of consults for AKI and decompensated heart failure, each of them is just slightly different enough. And it keeps the job really, really satisfying.
Do we have any more questions to answer, or does anybody else want to? I guess we kind of go through the chat. I mean, Yahida makes a great point, and the unfortunate truth is that as nephrology, and I have to just admit this, is that if you consult us, there's a pretty good chance that we might have to use dialysis. So I think anything that we can do to diminish dialysis is needed. And so all these trials that are coming out that are showing different strategies to augment diuresis, people that are trying strategies like hypertonic saline to increase diuresis, I think all of them are needed because we want to use the kidney for all of its glory. It's a lot better than a dialysis machine. And so I think that's a really important takeaway from this is that all of us, both nephrology, cardiology, the medicine services, want to do our best to preserve kidney function and use the tools that we have to improve patient outcomes. And that includes making sure we don't discharge patients that are volume overloaded, even though clinically they might look like it. So incorporating Vexus and daily Vexus, sometimes not daily, but every other day, just to see where you are so that you're making rational choices with de-escalation of diuretics. Maybe you need one more day. Um, when they come to the hospital, being aggressive, using the spot urine sodium as a way to increase that dose instead of waiting for a full day where you might start to get behind the 8 ball. All these are important ways to do that. But in the end, we also need to recognize that all of these things that we're doing have a lot of side effects. And so being cautious and watching things, if you're going to use tolvaptan, start a very low dose. If you're going to use a sequential nephron blockade, recognize the electrolyte derangements that could occur from that.
I might have missed this, but I think one thing I always struggle with is in patients who have hyponatremia that we're already using high dose loop diuretics, but not getting adequate response, but being worried about a thiazide worsening the hyponatremia as their approach to that.
That's a difficult situation, and Ali had mentioned it a little bit. I think that if you're able to achieve a volume removal with the addition of a thiazide, I think just as you're watching very closely, it's not like you can't use it at all. Could it make things worse? Certainly. However, I think you're trying multiple different strategies to remove fluid. So maybe the addition of an SGLT2 inhibitor might be a better choice at the beginning than a thiazide, for instance. maybe acetazolamide could be a different thing to do to augment. So maybe trying other strategies before going to straight to a thiazide. Because I think that's our typical approach. Is most people will look at heart failure exacerbation and start with a loop diuretic. First augmentation is with a thiazide diuretic. And then they start thinking about these other things. And maybe we should just like take a step back and say, hey, maybe we should start with an SGLT2 inhibitor instead of, there's so many other benefits of being on an SGLT2 inhibitor. But you also have to recognize that you might increase the creatinine, but we also recognize now that like having an increased creatinine during diuresis or augmentation is not necessarily a bad thing. So I think in the end, you might have to use a thiazide diuretic, and it's something that I think is reasonable to consider. But maybe you should consider some of these other alternative strategies first. Because if it works and you basically, what happens, and there's a nice Neph Madness post where there's a electron micrograph of the distal nephron, and they have, I think it's in rats. They basically took rats that were on like loop diuretics for several weeks, and then look at the distal nephron, and the distal nephron starts to hypertrophy and starts to compensate because they are getting all of the sodium dumped to them. And so giving someone a loop diuretic really can blunt that hypertrophy of the distal nephron and all those NCC channels that increase in response to the loss of NKCC2. And so that's why using a thiazide diuretic works so well in someone on chronic furosemide or loop diuretic use. So if that's the case, then you should still produce a hypotonic urine and actually improve the hyponatremia. So I think it is still possible that a thiazide diuretic can be useful even in hyponatremia.
Dr. Sparks. Thank you for the wonderful teaching points, and Glenn for scribing, and Yahira for bringing such a wonderful case. We had so much of physiology. I think everyone here is going to be falling in love with nephrology after this. So thank you so much, and hope to see you soon in the next case.
Thanks, everybody.
Thank you so much
Having
for your time.
us.
Thank you so much for
Have a
having
nice day.
Bye.
Bye.